So I want to just go over the Pulsara, sort of plans. So we've been in touch with their company, and we met with them at ISC. And essentially, what we'd like to do is, after we performed about an 8-month pilot at Memorial over the, past year, fall of last year, and what we realized is that it's an effective tool if used in the right context. And so what I mean by that is, Pulsara and their CEO will reinforce this. It's not a tool to fix your hospital process. It's a tool that complements whatever you're doing already. So if that means that you have a sequential workflow for taking your patients for door to needle or door to cath lab groin puncture, Pulsara is not necessarily going to overnight or even after 3 months just going to speed up your process. Okay, so if your process is broken, it'll likely remain broken even with Pulsara. We might reduce the number of minutes over time in terms of reducing because of phone calls and some of the redundancy that might take place with regards to communication. All right, and we realized this quickly. We didn't have a dramatic reduction in our door to needle time after Pulsara use, nor with door to puncture time. It sometimes helps reduce headaches for the ER. Instead of making 10 phone calls, perhaps now you're making 4 phone calls. So what I explained to their company is, and what they didn't quite grasp initially is, with neuro patients, unlike STEMI patients, the story is everything. And you can't communicate a story through an app. It's all about, as you just explained, your colleague at Holy Cross, that you have the clinical acumen, the clinical judgment. Medicine sometimes is more art than science, and you can't convey all of that in an app. So I'll give you an example, a classic Pulsara scenario. So let's say Hallandale EMS sends in a stroke alert, 55-year-old, left-sided weakness, maybe gaze preference, and then on arrival, the question became, do we want to act primarily based on this information, or do we still want to talk, do I still want to hear directly from my ER physician before I activate the lab? And the answer was, I need to hear directly, because just like she explained, it could be a seizure, it could be a migraine, who knows? And so that additional information that they gather, once they lay eyes on the patient is paramount. So that's one phone call that you could not replace. Then the other issues that we encountered in-house were, okay, you've now rolled the patient to CT. Who's actually entering, continuously that information into Pulsara? So we actually had to assign a nurse just dedicated to data entry in Pulsara. And many times, because we're also a level 1 trauma center, we couldn't, isolate one person, designate them just for Pulsara, because they were dealing with trauma, sepsis patients, STEMI, et cetera. So it was a personnel issue where, are you directly managing the patient, or are you going to be primarily in charge of communicating via Pulsara? Because if the essence of the app is, look, timely updates, right? So we realized we weren't getting timely updates. CT was being done, but the nurse was being occupied with other things. And I was finding out perhaps 5-10 minutes later, oh, CT's done, but nobody told me. So that kind of slowed us down in retrospect and speed things up. Where I think the value of some of these apps are, whether it's Pulsara or Triage or Join, whatever regions use, is the pre-hospital phase. So if EMS is looking to streamline their communication, instead of doing it through Medcom and then not knowing did the receiving hospital utilize that information, how are they acting on it, through this EMS at least can communicate effectively and is logged, and then on the receiving hospital they can say, okay, we got this stroke alert. Instead of using Medcom and writing it down and then communicating it with the neurointerventionalist or the neurologist, they can downstream just activate stroke alert. Those people get the information. But from there on, everything should just depend on what your existing process is. It shouldn't depend on an app, okay? And at least not until it's more automated, such that, let's say as you wheel the patient, there's like a band, perhaps a Pulsara band, that automatically tells you, okay, patient's now in CT, CT done, CTA done. So there's got to be some, mode of automation that, relies less on people and allows nurses to do their work. Because the feedback we got from our ER after 6-8 months of this was not very positive when it came to actual real life use in, time-sensitive situations. But we also recognize EMS loved it. So we're now going back to the drawing board, and we told them that, look, let's first start with EMS. And if agencies are really excited about using this, let's give it to them as a tool for pre-hospital communication. And then we'll have an iPad sitting next to Medcom. We'll receive that information, but all the subsequent steps will remain unchanged. So then we asked them, can you add the RACE Plus score so that when they roll out with this, we're not tweaking the app after the implementation. It's ready for use without many changes. Because the last thing we want to do is confuse the medics that are using this. First is the RACE scale, now it's RACE Plus. So we're just kind of patiently waiting. Now that the RACE Plus scale is rolled out, EMS crews are training with it. In about a month and a half, we'll have Pulsara that includes RACE Plus. So the only things that EMS, has to enter initially is, the hospital destination, the patient's name, and then everything else is optional. Okay, so this is the other thing. Is that, instead of asking EMS to enter a long list of information that they might currently be simultaneously adding into their, computers, their laptops. This could be something that if they wish to communicate based on protocols, they may have relationships with existing hospitals where they're triaging to, they can, but it shouldn't slow down their work. Then this is the most important part. So really all we need is name of the patient, even the last name, perhaps their age, last seen normal time, and what's the RACE Plus score, okay? So here, you can see that it's no longer, for those of you who are familiar with Pulsara, before it asked left-sided weakness, right-sided weakness, and based on that, it added or removed aphasia and agnosia. Now it just lists everything, and there's no laterality. And then after the score is done, there's also a reference area where they can look at individual, sort of how to score if they're not familiar. Everybody will be able to see it, RACE Plus is 7. If there's cortical signs, the app automatically adds a plus sign next to it. So they don't have to remember that, for cortical signs, I should add a plus next to the score. All right? And then they just hit alert, and that's it. So that information is sent to the receiving hospital. Yes, Niels.
You may remember going back to when we had first discussions about data collection in Broward, whether we would do that as a standalone interventional database or move and have it as part of Get With Guidelines. And the vision was, A, we could scale it beyond intervention and really capture the system of care and also go beyond Broward County, do it in Palm Beach, do it all over. The concern I have with an app like that, especially pushing for that with EMS, it actually goes past what we're really trying to achieve, which is we have EMS leaders that have a big stick. They're purchasing tools from SafetyPad or whatever. That technically should have that capability, and it will not put it in a separate database. It will have it in a database that could be then uploaded to Get With the Guidelines if you make them have an interface, which they don't right now.
Right.
And then you suddenly capture that whole information, and you can audit it, and you can say which portion of that score is really the most valuable one. For instance, I have a problem with all these apps because they miss one really key piece of information, and that is the pre-morbid modified ranking score. You can't really tell the paramedics how to score that, but you can do it with a phone call. You can basically have your ED physician go back and say, was that patient coming from a nursing home? Is they functional? Are they bedridden? Are they demented?
All right.
Because I'm going to not call in a $1,200 team for somebody that's in a nursing home and demented to do a stroke intervention. That's just not going to be, good public money spent. So that's really where we need to go to be able to have that communication through the existing tools, not create separate standalone tools. That's really my vision. But I agree that as an intermediate solution, it could maybe work. But I think long term that needs to be handled by the major vendors.
I don't disagree with you at all, but also keep in mind that the Pulsara app allows the communication, the actual voice communication as well. So even though you're entering the information into the app, if at any point in time, because the interventional doctors are also in the app, it's merely a matter of pushing a button, and they can call us and we can call them. So that dialogue can still happen.
But then, highly FR doesn't allow paramedics to carry the phone. It gets very complicated very quickly. It's not a solution that can
Sure.
scale quickly.
Right, and Pulsara's idea would be to at some point be able to work with the EPCR companies, so it's a single entry. So you're entering it into your PCR, it works the same through here, and the notification happens both ways. But we're still going to have a telephone, because no matter how advanced our laptops become, they're not making phone calls. So there's still going to be a telephone interface somewhere for us to make that contact.
If I may also have a comment on this. I know that in the heat of stroke alert, how stressed out the people involved are. And so stressed out that sometimes it feels difficult to fill out that simple single front page of the stroke alert form where we write that when was the patient last time seen normal. You know what I'm talking about. Now if we transfer this into an electronic system, just like Pulsara, where we have multiple lists, buttons, pull-down lists, selections, this will also add the frustration of the computerization itself. When eventually the phone or the iPad will be smashed to the floor because I just hate this whole system, you know?
And part of it is duplicate entries. If you have the name, the safety package, you have to enter the name again into Pulsara. So that's why I really think we need to push as part of the rollout to have that integrated.
Yeah.
It's not rocket science. It can be done. And the government makes it.
Yeah, I think the problem is that we don't have any control over what SafetyPad does, what ESO Solutions does, what Intermedics does, and whether we can get those platforms to cross and then to integrate together. That's the hard part, because I know in Broward County alone there's at least 3, if not 4 different EPCR providers that the agencies are using, and trying to get them all on the same page, you know, maybe like herding cats.
Yes, go ahead.
No, not on my trucks. And I think all the trucks in the south part of the county where we rolled this out initially all got iPhones on the trucks that are dedicated to the truck that were purchased either by the hospital system or by the EMS agency. So that's a good question. So Pulsara, while stroke is a piece of Pulsara, it's not their main focus. So Pulsara's ultimate overarching idea is to replace Medcom altogether, so that we don't have to make these phone calls to the hospital, that if you have anything from a trauma to a STEMI to a stroke to just your normal medical call, that can all be done through Pulsara, and the information goes over through the app to the hospital, and eliminating that Medcom radio call, not phone call, but radio call. So this is just a piece of it.
Yeah, it's a good question, and you know, that's one of the things that we brought up when we met with them after we concluded our pilot is, look, you know, just like with EMS, they can be expected to use an app just for stroke for some hospitals, and then routine modes of communication for other hospitals, and you can't expect hospitals to use an app just for one service line and then something else for STEMI, et cetera. So what they've done is, for hospitals that wish to use Pulsara, so they have a paid version, it includes everything, not just stroke, but STEMI, trauma, sepsis, and general category. So abdominal pain, you know, whatever it is that the patient is coming in for via EMS. And you know, that way it's more unified. EMS can use it for all purposes. Hospitals can use it for all purposes. But one thing I want to highlight, regardless of whatever you know, whatever you guys decide to use at your hospital, in order to avoid fragmentation among EMS, because we all know that, let's say Hallandale takes a percentage of patients to hospitals A, B, and C, like I said, their medics shouldn't be expected to remember that, okay, if I go to hospital A, I use Pulsara, if hospital B, I use Metcom, and hospital C, maybe nothing. So, you know, they want to make this free for EMS, okay? So that way, regardless of whichever hospitals are in a region, whether or not they're using this app or something else, at least it's universal amongst EMS because there's no barrier to entry, hopefully, right? The only thing you have to do is train the medics how to use the app, okay? And so, you know, as far as data collection, so I do know that once we decided to do our dashboards through Florida Puerto Rico Registry, we connected them, and Dr. Antevi has done a lot of this work, to quintiles. So the way Florida Puerto Rico Registry at UM is extracting the data is not directly through Get With The Guidelines, it's through the quintiles data company. Right, but it's, you know, it's the intermediary. Right. Yeah, so Pulsara is in conversation with quintiles to get that information and to get this, whatever data from the pre-hospital into Get With The Guidelines. I hope it works. I'm not sure what the status is. Yeah.
The bigger question then for me is, you know, maybe then get two sets of data because you're going to get some data from SafetyPath that's uploaded to MSTARS.
Yeah.
That is slightly different than what comes out of Pulsara. And so we really should focus to have one legal data set, which arguably is the EPCR, because that's your legal document. That's where you know, your archiving requirement and all that stuff. So I think they should be under
Use the microphone, please.
They should be under the gun to provide this communication capability because that's part of the RFP, right?
Yeah.
You know, if you bid out for providing a public service as a computer company, you should be able to fill those needs.
Yeah.
You can't really make a hospital buy these things. That's really my concern. In addition, I don't think it's going to work well.
The other thing, you know, that we ran into for implementation in hospital is, I think I can safely assume that probably most of your places are using Epic or Cerner, one of those systems, right? What are you guys using? Meditech. Okay, 1980s. All right, perfect. So I think majority of the hospitals are using the latest, you know, EHRs. So what we ran into with Pulsara is, like Niels pointed out, they don't connect to Epic. And they've tried, but so far it's been a challenge. So that's why everything in hospital seemed very redundant in terms of CT time acquisition, CTA, because Epic is accurately capturing those, and we did not want to, you know, have our Get With The Guidelines data suffer as a result of discrepancies between Pulsara and what's in Epic. The gold standard is your EHR, okay? And so until those two apps sync, it's an issue for us to fully adopt this in the hospital.
So I guess I'm just hearing kind of two different things, and my question would be: so how many EMS agencies, for example, in Broward, are using Pulsara, and is this something that
Currently zero, because after the pilot we stopped using it.
Okay. So is this something that we want to implement in the future? Because
well,
I
that's
think
what's up for discussion now, and
Okay.
not necessarily we don't have to take a vote, but this is the update. You know, this is now they're making it free for EMS to use. Hospitals don't have to use it if they don't wish to, because that's the paid version. And so we're at Memorial not going to be using the hospital version. It's just for EMS to send a stroke alert or STEMI alert.
so there's a free version.
Correct. It's the pre-hospital
And
version.
and the hospital will be able to use that for
Correct.
the pre-hospital.
Yeah, so you
but
just
then
have
you
an
don't-
iPad
Got it.
sitting in the ER next to your Medcom. And so if the EMS sends in a stroke alert, you can view it.
Got it. And so, I mean, I agree. I think in the end, I think the most important thing would be to have everything be uniform for all of, you know, the EMS agencies, so they don't have to fumble around with 3 different apps or 3 different systems. And who would be making that decision? I guess it would be EMS would be making that decision. Right?
And that's going to come from a much broader perspective, because you got to realize stroke is, again, just a single silo. From a Medcom replacement perspective of absolutely replacing Medcom altogether, that would be a much larger decision coming from the fire chief and prior communication as to whether that's the direction they want to go.
It took a decade just to merge Medcom, our county, right? So it's going to be a long process.
Yeah. So, I think this information, and you'll have it as reference with the slides that Laszlo will send out. Discuss amongst your hospitals what you would like to do, the agencies you work with. We've now met a couple of times with agencies that serve Memorial, and it seems that there is, I would say, unless, Mark, you disagree, I think there's significant interest for EMS to use something like this. So we're proceeding, but strategically. So phase 1 will be implementation via EMS, and if that seems like, after a couple of months there is compliance, because that's the other thing we ran into, is some agencies, even during the pilot, were using it, some were not, such as Hollywood Fire Rescue. They were not using it as much as Hallandale or Miramar. And so we want, if it's got to be all or nothing before we adopt it on the hospital side as of the next phase.